And, you know, so this is about, so every year, CMS releases the 2027 Medicare fee schedule. They do one for outpatient hospital departments, they do one for home health. The one I'm going to talk about today is about the physician fee schedule. So, hey, Richard, how are you? Um, so the Medicare fee schedule is really important, and especially when we talk about the physician fee schedule, because this is the methodology of how your doctors, when you're a Medicare beneficiary, how your physicians are paid in the outpatient setting, like when you go to their offices or you go to their clinics or they see you at home. And there's been a major change going into next year. I've talked about in my stuff on Blue Ant Media about the eugenics of healthcare and what this administration's doing with respect to how HHS and with the disability community and the VA and education and how they're the stuff that they've done with Project 2025. And this is the framework of how they're doing it. They're just hiding it in a document called the Medicare Physician Fee Schedule. So, yeah, I mean, for 20 years, Richard, the fee schedule's been just, pardon my language, everybody fucking insanely stupid. Imagine being in an occupation where you haven't had a raise in over 20 years. That's what physicians are doing today. We haven't had a raise, cost of living adjustment or a raise in 25 years. We've gotten cut. We've been sequestered. We've been asked to take a 1% here, 0.5% cut here, 2% here. It's literally been just crazy, insanely stupid. And keep in mind, practice prices don't change. You know, staff salaries keep going up. Supply costs keep going up. Malpractice keeps going up. Rent goes up. Mortgage rates go up and down, fluctuate. Water, electric, all these things that physicians, we still have to pay for all this stuff. And it comes out of every dollar that we obtain from insurance companies, or in this case, Medicare. So let me talk about the Medicare fee schedule. So one of the big changes they're going to do is they have given what they call a conversion factor. And what they do is they look at the bulk of the money there's a bulk of what they call the Medicare Trust Fund, which they've been rating, by the way. So as required by statute in 2026 that they passed as part of the big stupid fuck you bill, they proposed, so this is CMS. So this is the Center for Medicare and Medicaid Services. So this is underneath HHS. This is what Dr. Oz is the administrator for. So there are two models going into next year. So the first model is for qualifying alternative payment models, whereby like you go see your primary and they're part of an alternative payment model where they have a risk capitated group and they manage all those patients under that risk capitation. So if they're able to save money, the group gets a bonus at the end of the year. So that's like an alternative payment model. Then there's the other one for non-qualifying APM participants, which are most specialists, by the way. These are your orthopedic surgeons, unless they're in really big like APM groups, podiatrists, your oncology groups, your GI. Well, GI and renal are like, you're seeing a lot of consolidation with medical specialties in these larger groups. So, but like the more specialty stuff, like your hematology, podiatrists, ophthalmologists, derm. Okay. So they're more independent. So the way we do a procedure. So for example, a level 3 office visit for an established patient, which is a 99213, that has an RVU setting of 1.0. So that's a relative value unit. So that's the amount that they've calculated that between practice expense and actual physician time, what that procedure is worth as far as value units. So they multiply the value units by the conversion factor, and that's the rate of payment for the physician for that particular procedure code. So depending on whether it's a evaluation management EM service, like an office visit type charge for a new patient or established, for a surgery, for even draining an abscess in the office versus doing, say, a knee arthroplasty or an ankle arthroplasty or an ankle fusion or having your hip fracture repaired, All those have relative value units, those RVUs, and then that gets multiplied by the conversion factor. So for doctors participating in these alternative payment models, that rate is going to drop 40 cents from 33.57 this year to 33.17 next year. And then for the non-qualifying participants, which I fall into, it's going to go from 32, it's going from 33.40, which was this year, and it's dropping to 32.84. So when you look at a 56-cent decrease on the conversion factor, that conversion factor and I didn't do the math yet, so I'm just going to kind of do it real quick. So when you're talking about a conversion factor decrease of 56 cents, is equivalent to a 1.7% cut in the conversion factor. Now, that's only part of the story. The other part of the story is this is on top of add the 2% for the sequester. So if you guys remember the sequester, that was put in 2012 by the Tea Party when Ryan was the Speaker of the House, and they forced the administration and then they forced the agency to do a 2% cut to the Medicare fee schedule to help pay for what happened in 2008. And that was part of the bailout. So they have been cutting the physicians since 2012 to pay for the bank bailout in 2008. So that's never been rectified. That's still on the books. So that sequester still there. So this is another 1.7% cut in the conversion factor, which winds up for my specialty as a podiatrist is going to get cut totally about 4% across the board. So 4 cents for every, 4 cents for every dollar is now getting cut out of every CPT code, surgical code. Everything I do is now 4 cents less starting in 20. Now, this is a proposed rule, but this is, if it goes through, this is what it's going to be for 2027. But what does that mean? It's 4%. So a 4% cut on top of a 1.7% cut winds up being a total of about 6% off the total package plus the sequester. So it's 4% plus 3.7%, which basically almost equates to like an 8% cut for next year. Now, 8% on the dollar is huge because now that 8% is now cutting into overhead costs. And it's cutting into my profit margin to be able to hire more staff, to expand services, to marketing, advertising, bringing in new technologies. This is what it is. So my specialty is at 4%. So dermatology is getting hit 9. General surgery is getting hit 6. So in essence, what is this actually is? So this is what the government's idea of eugenicizing access to Medicare beneficiaries, because they're not seeing the amount of patients they want to convert from regular Medicare to Medicare Advantage. So as a result of that, because they're not seeing those numbers move fast enough, so right now about 52 to 53% of the Medicare population is actually on Medicare Advantage, because they would rather see those numbers look like 60, 70%, because those numbers aren't there, they're going after the physicians. So they figure by cutting back access that they hopefully what they're thinking is if more providers drop Medicare, so they don't become Medicare providers, so they become non-participating, then this is what reduces access for Medicare beneficiaries. So what does this mean? If you're non-participating as a Medicare provider, that means that you cannot see patients in a hospital. You cannot see patients, and you can still go to a surgery center, but those patients then have to pay you cash for those services. You then have to provide the patient the claim forms or the information for the patients to fill out their own claim forms to submit the claim to Medicare for Medicare to reimburse the patient. So this is almost like kind of how you convert the entire country into a direct care pay model. Now, I know for a fact that most patients don't have enough cash to even pay for a $500 procedure, let alone a $2,000 procedure, let alone a $3,000 procedure. And you guys all of us, we're seeing prices now. Gasoline's up to $4 a gallon. Steak. I mean, I saw the price of fillets last week. It was what, $36 a pound for fillet. That's crazy. But because of what we're seeing in the economy, now you're talking about restricting access to Medicare beneficiaries, which means there's going to be less doctors seeing patients and less access, which means people aren't able to get the care. And then when you start adding in all this stuff on top of what they want to do with the disability community, with the Olmstead stuff, with the disability docket, and start institutionalizing more people or cutting them out of society entirely, this is what eugenics looks like in healthcare. They've already done it to education. They want to do it to the VA. They've already done it to the interior. And this has been the plan, everybody. This has been the plan. I mean, United Citizens talk about this. I know we've talked about it on Blue Ant Media. I've talked about it. I know Nick Peros talked about this, where it's a 3-stage process. And Doge was the first one, right? Doge was wipe out the workforce. So if the agencies don't have the people to work in the agency, then the agency can't properly function. Second part is then privatize it. Make people go on private health insurance managed by private companies who are for profit, by the way. United, Aetna, Blues, Cigna, they are all for profit companies. Now, prior to 1973, if you were an insurance company, you had to be a nonprofit. The deregulation after 1973 and then accelerated by the Reagan administration is where we are today, with all of these for-profit hospital corporations, for-profit insurance companies. So this is where we're at. So, all right. So getting back to the fee schedule, because this is really what this is about. So, so that's the first one. The really other big one that's in this is they want to knock down there's a modifier that most physicians use when they do a procedure on the same day that they do an evaluation management service. So for example, you come to see me as a patient and you're a type 2 diabetic or you have vascular disease, but then you're also coming in, say, like you got heel pain. Okay. And you want me to do an injection in your heel. So I do my evaluation for your overall systemic, and that covers the evaluation management service. And then and then I would provide a heel injection to you. As painful as it is for your plantar fascia, we do the injection. So under the current plan, the evaluation management service gets paid at 100%. I get the full service fee, $95.69 for the EM service. The injection for the plantar fasciitis, which is a 20550 trigger point injection, gets paid at like 63. And I get paid a little bit for the steroid with the J code for the drug. So all in all, those get paid in full at 100%. What they want moving into next year, which is what the comments are about, and I know the AMA is going to comment on this and they're going to be pushing back really hard, is they basically want to take instead of paying the EM service in full, if it's done in conjunction on the same day as a procedure, they want to cut the evaluation management service by 50%. They've proposed 25, but they're willing to do 50. Now, what does this mean? So there's legislation and there's statutes that under the Social Security Act that is called the Multiple Payment Reduction Rule, or the MPRR. That means if I do multiple procedures on the same day, for example, if I do, surgery is a great example for this. So if I'm going to do your foot surgery and I do your bunion and I do 2 hammer toes, the bunionectomy is paid in full at 100%, and then the 2 hammer toes are paid at 50%. Multiple payment reduction. I don't get 100% of each of those other procedures to do. I get 50. What they want to do is take that evaluation management service and consider it like a procedure and then pay that at 50%. So you're cutting into the physician reimbursements even more by another 50% on top of the 8% that they already are going to cut for next year. So everybody, this is how you eugenicize healthcare. You take the payment model and you start strangulating it where the physicians can't survive. on the outpatient side. Now, the physicians that belong to multi-specialty groups or big groups like that, they're RVU based. So what they do is the more patients they see, the more revenue value units they bill out. And then the groups get paid based on how the doctors bill and how they select their relative value units. But at the end of the day, what happens is in all these contracts with these physicians is they have to bill X number of RVUs to qualify for bonuses. But now what's going to happen is that whole model is going to shrink and compress because the RVUs are going to be valued at 50% less. So the physician's going to have to bill 2X to make X. They're going to have to see 2X to make X this year. They're going to have to see 2X next year. To be even more profitable, they're going to have to see 3 and 4X. Now, when you start stratifying all this out, is that providers that don't see Medicare Advantage patients are literally going to see a shrinking population of Medicare beneficiaries who are on traditional red, white, blue Medicare, whether or not they have a supplement or not. And when that population starts to compress and shrink, now you're not seeing as many patients. And as a result, what happens to these physicians is they're going to get audited by the groups that they work with. And some of these groups are owned by capital investment firms. So if you're not making the cut financially, they fire you. Now, if you're a 60-year-old physician and you still have kids in college and you've got 10 or 12 years left in practice and you get fired because you're not generating enough revenue and you've got a restrictive covenant in place where you can't just work in the same community and you can't see the same patient populations because you have a restriction in the group, you're contractually prevented for working against that area and that group because you just left the group for up to 2 years or longer, depending on the restrictive covenant, the hospital you can't even see patients at, you're going to lose physicians. And this is going to create the healthcare crisis that they want to manufacture. So those are the two big ones. There's more stuff that affects wound care, and I'm not going to get into that kind of stuff, but it's really just a scary proposition of where we're at. So if you are a Medicare beneficiary, there's open public comments until August 14th. I will post it on my feed in a separate post on Substack. But if you can, the contractors never hear from patients. They never hear. Gloria, I'll get to your question in a second. So they never hear from beneficiaries. Beneficiaries don't make comments, so they don't hear from patients. But when they hear from patients is when there's action. So the action items here are to be to call your congressman, especially the ones that sit on Ways and Means. If you live in a jurisdiction, I'll post all of the senators that sit on the Senate Help Committee and the Ways and Means in the House, because they are the ones that govern CMS. So I'll post that in a separate post after the show today. So Gloria's question is, why do they want a healthcare crisis? Well, think about it, Gloria. If they want to kill off part of the population because these people are fascists, they are dangerous, they're eugenicists, less people less people to take care of and less people to pay for means more money for them. It means less financial out. It's less financial out on the government side. This whole thing isn't about whether or not you're going to get better care. This whole thing is about whether or not they can save $2,500 a year or up to $10,000 a year or up to $25,000 a year by making sure that patients don't have access to healthcare per patient. And now multiply that by tens of millions. It's about how they restrict money going out from the federal treasury to make sure that we have a ballroom, to make sure that he gets these new Corinthian columns on the White House, to make sure that he gets his permanent helipad at the White House. I mean, this is the shit that they're doing. It's all about, and it's all in Project 2025. We've been warning everybody about it, and here we are, it's reality. But this is the kind of thing that affects everybody. And we have this problem in this country of, I don't have to deal with it because it doesn't affect me. It's not my problem. Well, this is everybody. This is your Medicare FICA money that you paid into the system for when you were working. These are your Medicare payroll taxes. This is our money that they are fucking with. And that's why they want a healthcare crisis, because it means that less of that money is available for taxpayers to utilize under healthcare, because they don't want universal healthcare, because universal healthcare means everybody gets taken care of and people can be healthier. Now, the other side of this is the system is broken. It's inherently broken. For years, Medicare was established and the Social Security Act was established to take care of the elderly population or the retired population for things that happen, right? It's a reactive healthcare market. You cut your leg, you go to the ER, you get stitched up, you go home. You have a heart attack, you go to the ER, you get catheterized, you get your stents, you go home, right? You need surgery, you need a hip replacement, you fracture your hip, you get to what we don't have, what we're not paying for is preventative care. I, as a provider, do not get paid bonus money for keeping you out of the hospital if you're diabetic and you don't wind up with an amputation. Your primary care physician doesn't get paid extra money with managing your cardiac condition to keep you out of the hospital for a heart attack. So on and so forth with every medical provider. Like the oncologists don't get paid if they don't get paid bonus money because you don't get cancer. So we live in a very reactive healthcare environment and healthcare economic system that is no longer working because we're now upside down on the number of beneficiaries that need services versus the amount of money coming in on the payroll cycle. And when you cut payroll taxes like doofus, droopy shithead president decided to do, guess what? There's less money coming into the market and coming into the system. So you're naturally going to run a negative shortfall with the Medicare trust fund. Now, they've rated the trust fund 3 times. They rated it to pay for the Iraq war. Trump rated it to pay for the first set of tax cuts in 2016. And now he's rating it again to pay for this war. So if we don't start speaking up, because they're basically spending our money. So this is where we're at, everybody. So it's been about 23 minutes. Does anybody have any other questions? Because I just want everybody to be aware of what's going on going into next year. That this is a proposed rule right now. It's not it's a proposed rule, so they're taking comments. I know the AMA is going to push back. I'm pushing back from the Wound Healing Society and the APMA. And I'll put stuff. I'll do another post in my Substack feed where everybody can have action items and like a script to call your congresspeople and your senators. So the thing is, though, it's not about the immigrants. The immigrants don't get health care. The only time they get health care is when they go to the emergency room and they're covered under EMTALA. They don't qualify for Medicare. They don't qualify for Medicaid. So this whole bullshit about immigrants getting health care has been a lie the whole time. Unless they buy private insurance, which they're entitled to. They just don't qualify for government services unless they wind up at the hospital in the emergency department. And I will definitely put the post up, but this is what eugenics looks like in healthcare. Hey, David, how are you? No, I'm just talking about the Medicare fee schedule and the changes they're doing into next year. And I know there's a lot of action items, everybody. Everybody's going to be screaming at you to do action items coming into the fall, but this is why elections matter. This is why electing the right people matter. Electing the right type of people matter. It shouldn't just be single issue voter on Israel or Palestine or healthcare or absolutely. Yeah. Yeah. Amy, they want us dead. They want everybody dead except for this little small group of people that think that they have the right to tell everybody how to live their lives. And they want to kill off the disabled population. They want to kill off the VA population. They want to, they look at everybody. They look at us as line items, as editable, deletable line items on a spreadsheet. That's how they look at us. Your tax ID number becomes a line item. Your social security number is a line item editable thing. And it's disgusting. You ask any physician why they got into medicine in the first place. It was because I wanted to take care of patients, make a nice living, have a nice lifestyle, and be able to retire knowing I took care of patients in my community. Not spend half of my day chasing administrative paperwork that they send me or chasing, you know, 3 pages of denials on a Medicare EOB that I get because they don't wanna pay for a specific procedure. This is 3 pages of Medicare denials right here that I am now spending time administratively to go after because it's just the way the system is set up. And it's stupid stuff like, "We're just not gonna pay for this," and they give me a bullshit code error. It's not even legitimate, you know, or this is what the system is set up now. It is it is a administrative nightmare. They make it difficult for Medicare beneficiaries every October to do open enrollment because now you're getting inundated with, "Oh, sign up for this Medicare Advantage plan. We'll give you free groceries." If you are on regular traditional Medicare, do not change anything. I can't stress this enough. If you are on traditional red, white, blue Medicare, do not change your insurance to go to a Medicare Advantage plan. It's what they want. Now, I know every provider, for the most part, if you don't have a supplemental insurance, they'll pretty much waive off the 20%. They're happy if you're a Medicare beneficiary. We'll take the 80% because we know what the plan is. Like, we're able to deal with it, and you still retain all of your choices for physicians, for home health, for drug therapy. You're going to get the Cadillac and the Ferrari therapy. If you go to Medicare Advantage, if you sign up for Humana, you're going to get what Humana tells you they want. If you sign up for Medicare Advantage tells you what they're going to give you. You're not getting the Ferrari pacemaker. You're going to get the Buick. Not that there's anything wrong with the Buick, but if the Ferrari lasts 15 years versus 10 and you don't need a generator change because the pacemaker is only going to last 10 years and they got to do a battery change versus 15, what's better for your life, really? It's having less procedures, right? And living longer and having a better life. So this is why it's so important when you're making these choices as beneficiaries to pick your insurance and your supplements. Medicare, there's a reason why we call it Medicare Disadvantage. You've heard Egberto talk about this with me. When you go on Medicare Advantage, it costs 20% more to take care of you as a Medicare beneficiary when you're on Medicare Advantage versus traditional Medicare. Because the commercial policies are the commercial insurances use their commercial policies, not Medicare policies, because there's no enforcement. So they default to their commercial policies, which are much more restrictive, much more experimental, investigational, and it costs more money because it takes longer to get you better. So if you have the opportunity to come off of Medicare Advantage or to never sign up for it in the first place, that is your best option. It's always your best option. But I totally understand for financial reasons, if you cannot afford a supplement, if you can't, talk to your physicians. Talk to your primary about it before you make a bad decision. And if you have agents calling your house saying, "Hey, sign up for this plan and we'll give you free pairs of shoes and you'll get $200 of groceries." It's a sell point specifically. Remember, insurance agents sell you a package that gets them to Hawaii. They're incentivized to sell specific plans that gets them, because the more they sell, the more points they earn with whatever insurance, and then they get award points to go on trips. So you do what's best for you, not what's best for them. And if anybody tries to change your healthcare insurance without your authorization, make sure you get their name and number and write down what company they're from and what insurance they're selling and report it to Medicare. You can call the Medicare ombudsperson and report it. But this is going to take all of us. I can't do this by myself. I'm only one person. But if we all pull together and we all work as a community, then we are doing it on our own. So Sacred, great question. So there are agents specifically that work only with Medicare and Medicare supplement plans. If you want to private message me, I will give you a contact information of the person that I refer patients to. The agent I work with, she's licensed in I think 43 states. Um, and she's really great to work with. I call her the Medicare queen. But I don't want to like advertise her business on my Substack. If you private message me, I will be more than happy to give you her information. Um, but and she'll go through all of your stuff with you and then help you kind of put you in the right plans of where you need to be. So if you're turning 67 this year or you're in your 60s and you are at that point in your life where you're deciding, should I take Medicare at 62? Should I take it at 65? I know they say the longer you wait, it's better. I don't know if there's going to be any money left, to be honest with you. Um, so if you're eligible now to take Medicare Part B and Social Security, maybe it's a good time to take it. Um, I know if you're 66 in 10 months, you can apply for your age 67 benefits. If you're 62, you're going to get a lot less money, but at least you'll start pulling it in. And then don't wait to go on Medicare Part B. If you're eligible for Medicare Part B, go on Medicare Part B, even if you're still working. If you're still working and have third party insurance with like your employer, it's okay. Your Medicare will become secondary. The primary employer insurance will still be primary if the employer has more than 20 employees, like a group insurance. Um, so like we have friends of ours who they work for airlines and the airline insurance, they still are on it and it's their primary insurance and then their Medicare is supplemental. Hey, Lynette. So there are people who understand how this works and it's confusing for a reason is because they say, oh, go on Medicare Advantage because it's an easier choice. I got to tell you, you go on Humana, you are stuck. You can only see a Humana physician. You can only see Humana specialists and you have to only go to where they tell you to go. Please smash those hearts for me, everybody. More hearts you smash, the more people see this video. Um, and it's an important message, and I appreciate all 33 of you that are watching. So thank you very much for spending part of your day with me. So that's what happens. You get stuck in these networks, and because you get stuck in these networks, your choices get really limited. Especially if you need specialty care, if you need IV infusion therapy, if you need home health, if you need specialty surgical dressings. And I see Substacks acting up a little bit. So this is where we're at today. I'm hoping we won't be there anytime soon, but I'm hoping that in essence we'll be able to move past all this in the next Congress and get into a better position. So why is Substack acting up on me? I froze. What's going on here? Can everybody still hear me? I'm going to come back in. Oh, there we go. Okay. Oh, there we go. Okay. Sorry, everybody. Sorry for the little glitchy there for about 30 seconds. Right. So if you're on regular Medicare, no HMOs, no pre-authorizations, no prior authorizations, no prerequisite stuff. You show up and you go. And that's the beauty of the system, and that's the way it's supposed to be. So, no, thanks. It was getting kind of jumpy on my end, everybody. So, but that's the best part about regular Medicare is that regular Medicare was basically the model of the old traditional insurance that we used to have years ago, where it was the old Blue Cross Dimension 4 plans. or the traditional United Healthcare where it was everything was paid at 100%. You just paid your deductible and you had 100% coverage on everything. You didn't have copays, no co-insurances, none of this crap. That's what Medicare was pretty much designed on. But we're at a situation now where this is so important. Yes, now I'm gonna rebroadcast this. Like I'm gonna like review it and I'm gonna repost it immediately. Yeah, there was maybe a $5 deductible or $100 deductible. I think I remember having a plan that had a $500 deductible, and I had massive back surgery. Like I had 3 or 4 back surgeries in 1 year, and I only had to pay $500. Um, so right. So if you're on Advantage now, there are certain criteria that you can get out of it. If you are in the first year of your Advantage plan, you can get out of it. If you've been on Advantage for a few years, you're going to have to wait till open enrollment in October to make your selections for January. So if you've been in Medicare Advantage for a couple of years, you're kind of stuck. Um, if you're in an area where you're on Medicare Advantage and there's no providers and it becomes a geographical problem for you to actually see somebody, then yes, you can get out of it. So there's certain criteria on how to get out of Medicare Advantage, but it's really specialized. Um, but how is it making sense if it costs 20% more to be on Medicare Advantage? Not for you. I'm talking about the government. As the US federal, it literally costs CMS plus 20% for every patient that's Medicare eligible that goes on Medicare Advantage. It costs 20% more. How the hell did that happen? Right? It's not saving money. It's a waste of money and it's only profiteering the insurance companies because they're not spending it on the beneficiaries. I can tell you that. That's not happening. And everybody drink more water. That's my health, drink more water. Water's healthy for you. And that's pretty much what it was. It was about funneling more. The original thought behind Medicare Advantage was to try to make the system more efficient. But over the years, what the insurance companies found was that by asking for more money per beneficiary and looking at these things called these hierarchical clinical codes, like if you're type 2 diabetic, if you have vascular disease, if you've had a cardiac condition, they get more money from the government. So they ask CMS for more money. And it winds up being this extra expenditure that isn't necessary. Because if you have regular Medicare, you show up at your cardiologist, you go get your stent, and it doesn't cost anything more. But if you're on Medicare Advantage, now there's delays and denials, and it costs more money because they're trying to manage the case as opposed to treating the beneficiary. And that's the sad part about the whole system is that the patients are winding up getting screwed, is that you actually wind up in a worse position when you're on Medicare Advantage. So I was only supposed to go 25 minutes. We're at 40. So I'm going to wrap this up pretty quickly here, everybody. I'll take maybe 1 or 2 more questions if everybody has one. If not, I really appreciate everybody staying on today and watching. And I will post this right afterward. I'll post some clips and I'll work on this afternoon. Or tomorrow I'll put up the script and the site for the Medicare comments that you can submit comments to. And it doesn't have to be anything extravagant. They're not looking at anything. You can say, I am a Medicare beneficiary. I'm aware of the fee schedule change, and these are the reasons why this is a bad idea. And listen, don't send emails to your congressman. You call their offices. And I'll put a list up with all the offices and all their phone numbers of House Ways and Means and the Senate Help Committee so that you can reach out to these senators and Congress people immediately. And I'll put that out probably later today or tomorrow. I'll have this put out in a few hours. I just need to review it and we'll go from there. So hope everybody has a great rest of the day. Don't forget to catch me on the Diogenes show on Thursday at 12:30 with Nick and Evan. And I know I've got a couple of shows coming up. We're going to do one with Angie Rasmussen. And with our special guest, we're trying to schedule her as Kate Rubens, Dr. Kate Rubens, who's a microbiologist who actually is actually she's the director of the Tibeti Institute of Space and Global Biomedicine. She was actually up in the space station, the ISS. She was the first human being to sequence DNA in space. So that's going to be a really interesting conversation for those of you. And Kate's just a great person. I've had the opportunity to speak with her a couple times. So with that, we got the Diogenes show. I've got a couple shows coming up with Marlon and Egberto. I have one coming up with Cliff and Dave Schuster on Blue Ant Media. And I know Dana and I are going to be doing another show soon. So everybody just keep staying tuned. We're gonna keep doing this. I've got a couple candidate interviews coming up. I know I'm working with Nicole Lachlan in Florida 26, trying to get her on, and I know I've got Victoria Doyle scheduled again for Florida 23. And everybody have a great rest of the day, and thank you so much for tuning in. You can subscribe to my Substack. I do have a very small paid subscriber one. That one goes to a fund that I am matching that will go to other creators. That I'm working on a program with Blue Ant Media that we're going to take all that money and fund new creators to help kind of get them started. And so your $30 annual subscription is not wasted. It gets matched by me and goes into a fund into Blue Ant Media that we are funding younger creators and starting a program probably in January 2027. So we're going to help people kind of move through Substack and build their independent creativeness. And that's kind of what that annual subscription is for. So everybody, thank you so much for joining and have a great rest of the afternoon and enjoy your Tuesday and have a wonderful day and stay healthy.